infection, and then if they had any surgeries for that, you can mention that. Otherwise, you don't need to. But for example, let's say they had a nephrostomy put in because they had an obstructing system, so you could put that in. And then past medical history, usually it will self-populate from here. And then you can write comorbidities and just check the relevant ones as well. And then in this section, clinical narrative, you can just give a summary of in terms of what happened whilst they were in ICU and like how they came in. So for example, it'd be like Mr. Test came into MPH-ED with something with lethargy plus urinary frequency for the past few days, but was found to be hypotensive, came into MPH ICU for, I don't know, anacopic support, had antibiotics, etc., found to have some, I don't know, kidney stone that was obstructing. In the system, had nephrostomy insertion, and then improved and discharged home from ICU. That would be it. And then if you give like a plan in terms of what's going to happen once they follow up as an outpatient, for example, in a patient who is surgical, sometimes they'll have post-op things. Obviously, you can speak to the relevant surgical team about what to be done. So, for example, you can be like, JJ stent insertion as OP in 3 weeks' time, ureteroscopy and laser to fragmentation of system in 6 weeks' time. And then you can put relevant investigations. So, for example, they had a CTKV showing 4 millimeter stone in left kidney, left PJ. And then outstanding actions, recommendations. You can put like plan. To be honest, you can just say this because that's what that needs to be done. And then if you need the GP to do anything, GP to repeat blood tests for low phosphate and magnesium in 1 month. You can write that there. And then you can just write as above. And then, yeah, and then the next bit and the more important bit you can go into, and what Nav can help me with is writing the discharge drugs and why that's important. So now, if you want to take over, my friend.
Sure. If you want to, can you save that for me?
Yeah.
On ePro, yeah?
Yeah.
I'm just going to share my screen and then make a start from there. I'm assuming it's the same one as I am, so I'm hoping it's the same thing. Is it this one, right? Test B EC test, right?
I don't think so. I think it's a different one, but just double check.
Oh, it's fine. Don't worry. I'll just use this one.
I renamed it ICU admission for sepsis.
Oh, did you? Oh, I see.
Yeah, it doesn't matter. Doesn't matter.
That's fine. That's all right. Okay. So I don't know what introduction we've had already. So because I thought this was cancelled, but anyway, the idea of this presentation is not to replace any sort of induction training that we're having as that you guys normally have when you start. So if you haven't had any ePro training, I suggest that you book this in with ePro, perhaps through your manager, or I think there's an online ELMS training as well. So this is just a hints and tips kind of session, just to give you some idea of how to do a discharge summary, but it doesn't replace your actual core training that you get. So if we start off with oh god, admission. Okay, if I just try and amend details, so I'm just going to go through firstly how to add an allergy onto a patient. So if you go back to the screen, so you checked your patient's name and details, so address and date of birth, and you want to add an allergy, you can simply click the top bar and select this adverse reactions tab and click details. And then that should take you to a screen that looks something similar to this. So if you notice, let's say on the drug chart, it says a patient has I don't know, allergy to erythromycin, then we can add in an allergy. So you can type in the allergen, so erythromycin, and it should pre-populate a list. So if you see here, you click erythromycin, and then if you know what the reaction type is, so if you know that it's a skin, like a non-specific rash, you can click that. In the notes, you can write down anything additional. So to legs, let's say, if they've got a reaction to their legs. And yeah, and if the patient was your source, then you click patient, then you hit save, and that should take you to back to the screen where it will tell you where it's actually populated the list on. Now you need to validate some adverse drug reactions as well. So you need to click validate, and then that will confirm the list that you have in front of you. The idea behind updating this allergen tab is to make sure that everyone is aware of the allergies a patient has, not just on the drug chart, but also on ePro as well, just in case the patient gets readmitted in the future, or if someone's checking ePro and not checking the drug chart. This is just another area that we can improve our documentation of allergies and adverse drug reactions. So if you notice any patient having any allergies to anything, we should document on here as well as in the notes and on the drug chart. So let's say, for example, you can even write down, if you're not too sure what the reaction is, you can even write down unknown reaction, and you can write down patient unsure. If you think if there's an allergy that the patient's not too sure about what the reaction is, you can simply click at that as patient not sure, and then again hit save and you can always amend it if you find more information out about that particular allergy. So that's covering allergies. Now, in terms of how to add drugs to a TTA, so I'm just going to try and find a TTA that I can amend. Ignore this bit. This is just for me to show you guys how to do it. Amend the TTA. So you'll see this drug list. So once you've done the clinical summary, so your clinical information is complete and your outstanding actions and your other necessary boxes are filled in, we should now add in what our medicines are. So always before you add any drugs, make sure you got the right patient, the right drug chart. You'd be surprised by how many incidences we have of people are prescribed the wrong things because they're not looking at the patient's name. So if you want to add a drug, you add drugs tab. Now in here you'll say discharge tabs, current drugs, past drugs, and drugs on admission. So in here we're going to add in some medication. So if I go to, so if I add a drug to this discharge summary, will take me to this tab. So you always add a drug from the drugs tab, and this should be your discharge date that you're discharging the patient. So ignore this. This is just because it's an old discharge summary. Now in this box, you're going to type in the drug that you want to prescribe. So let's say for Jung's patient, we had urinary stones. So you want to give some urodeoxy. I spelled it wrong. So if you spell the drug wrong, it won't obviously turn up. So yeah, so urodeoxycholic acid. If you click the drug, that will obviously bring up that drug profile. But if you notice on customize, sorry, I'm just gonna start that again. So before you even click a drug, you can see many different drugs and many different doses. Now, the idea is you select the drug which matches your dose. So let's say the patient was on 500 mg twice a day, you might want to select that one. However, if you can't see the drug that you're looking for, so let's say you're looking for something that's in a different formulation, so let's say liquid, you can select see more, and you might see a liquid formulation there if you know your patient's only taking medicines as a liquid. So don't be afraid to press see more. That's often sometimes the wrong formulation selected because see more is not selected. So that's something just to be aware of. So let's say this patient is taking 500 mg twice a day. Now, once we select this profile, it's going to ask you what's the therapeutic indication. So we can say here, let's just click anything. So treatment of biliary cirrhosis. So if we're going to So if you want the specific timings, we can do morning and evening. And interestingly, for this now, so the next bit is the date. So date prescribed. So we can put down the date as actually prescribed. So let's say if the patient had it on the 20th, we can say the 20th. They're starting it on the same. So they're starting it same day, the 20th. The end date. Now your end date and review date would depend upon obviously when your follow-up is. So if you do 6 weeks, you want to do 6 weeks, so 6W, and that'll be 6 weeks, and it automatically calculates 6 weeks. So that's like a little short code for yourselves. Now we started this medication newly during admission, so it's a newly started drug. If it was a patient that was, if it was a drug that was prescribed prior to admission, you might want to select continued, or likewise, if you know that we've changed the dose during the admission, then we can select changed. Now, it will also prompt you to write in this box as well. So let's say we change a dose, we can write down any particular reason that you want. So it's just for the GP to know that the medications have changed. Now, the reason behind doing this is that it makes it a bit more, when your ePro discharge summary is printed off, you'll notice different boxes. So you'll notice new medication, you'll notice changed or altered medication, and a continued medication, and even a stopped medication column. Now, this just makes it a bit more simplified for the GP to follow what drugs have been started, what drugs have been changed, and what drugs have been continued, and likewise what have been stopped. So it's always good that we ensure that this status is changed according to what we are doing in hospital. Just so it's clear for everyone, and including a reason as well. So changed, say, as per renal function. Yeah, so you could do that, or you could say any other notes that you might find interesting. So if we do started here, now if you also here you wanted to be extra thorough, you can write down to be reviewed in 6 weeks in clinic, and then that's another direction that it won't get lost anywhere, and that everyone knows that the patient's going to be reviewed in 6 weeks, and we have this review date on the 8th of December 2022. Now that allows you to make amendments to the directions. So if you wanted to add anything else, you could add it in there physically as well. This next bit, and once you're done with that, then you hit save. See, this is why it's going to prompt you to validate your adverse drug reactions before you start. So validate. Once you validated it, you'll be allowed to save that drug profile, and that'll get added to the patient's TTAs and directions. For some reason, it's continuing. It's fine. So that's saved, and now that's added to your drugs tab. Yeah. Now we can see here that this patient's also prescribed clarithromycin. Let's say we wanted to delete this drug. You just hover over it, left click, and then select delete. And then your reason for deletion, you can say changed, delete, and you can always add a new drug. So likewise, again, I'm going to show you how to do an antibiotic now. So amoxicillin. So you know this patient has a liquid amoxicillin. So right now you can see 2 different drug profiles have been selected. So ePro has told you that it contains, there's colmoxiclav and there's also amoxicillin. So make sure you select the right drug. So amoxicillin, and you want the liquid preparation. So 500 milligrams 3 times a day of the liquid oral solution. Select that. Now, if we wanted to, let's say, give this patient 250 of the amoxicillin 3 times a day, we can do click customize, and you can make an amendment to the dose. So you go down 250, and then that should automatically change to take 5 mils 3 times a day. And we know the consultant wants us to have it for 7 days, so we're going to write down 7D in the end day box, and that should automatically calculate an end date of the 3rd of November. And then we're going to click save, and then that should again now add it on to our discharge summary. I'm going to also show you how to free type a drug. So let's say for some reason a drug that doesn't come up on our ePro list, we can actually free type a drug as well. So I'm going to think of a drug that's free typeable. I think everything should come up, but there shouldn't be any reason for you to free type a drug. But if you ever see this FT at the bottom, this means free type. And this, if you click this box, it will allow you to actually override the pre-printed, the drop-down list, sorry. So it will allow you to override that particular function that prevents you from prescribing. But you should only usually use this if you can't find the drug, but everything should be on ePro. And if you're having difficulty following it, then you should maybe ask your pharmacist before you just override button. But there is an option of doing it if you're unaware. Let's say, for example, you wanted to prescribe a course. So let's say prednisolone. So prednisolone we often see as a weaning course. So you do prednisolone 10 milligrams every morning. Let's say the patient was using it for, I don't know, COPD. Let's just use that as an example. So we want to wean it down. So let's say we want this patient to have it for 3 days. We'd put an end date of 3 days for this particular profile. And then also we can write down here brackets for 3 days. And then hit save. And let's say you wanted to wean it down to 5 milligrams thereafter. We have to select, another profile. So if you go to add drugs again, select prednisolone, 5 milligrams. The end date. So this particular prednisolone is not going to start the same time as our previous one. So we're going to start this on the 30th because that's after the 3 days. And we're going to put down an end date of 3 days after. So yeah. So end it on the 1st and hit save. So that is how you, and then you can also add in if you're extra thorough. For 3 days, then stop. And that's how you should do a weaning profile. So each individual drug should have an end date and a start date, always ensuring that it's clear for everyone, each individual profile. You can also prescribe everything in one box, but that's not the way we should do it. So I think this is the clearest way of doing a weaning regimen. So just quickly touching on that. Now, so yeah, that's just touching on continued medication, new medication, how to do steroids, end dates and review dates, which are really important. Another thing that you might see is some prescriptions from a previous discharge, so a past discharge summary. You can see this patient was on warfarin prior to admission. It's not always the case where a patient's still on old medication they're currently taking. So if you look at this past tab, so it's always important that you actually make sure you look at the drug chart and look at the medicines reconciliation page of our drug chart. So normally at the front of the drug chart's on ICU, but on other wards it will be on page 2 of the drug chart. Now this will indicate what the patient's actually taking prior to admission. So this might be from a previous discharge summary a while ago, and the patient might not necessarily be taking these medications on ePro because it doesn't get updated as frequently as, let's say, a GP record would. So I wouldn't use this as a source for doing your medicines reconciliation unless it's a recent admission. So just be aware of that. ePro might pull or might ask you about these past medications. So always review the medication you're prescribing before you actually prescribe it onto the discharge summary. Otherwise, it could lead to an error happening. So if you go back to this document, you can see now it's populated our list of medications. So over here, it's telling us that we're going to prescribe some prednisolone, some amoxicillin, and some ursodeoxycholic acid. Now, when you're done with this, you write down, you have to select discharge drugs are complete as yes. And you're going to supply it from pharmacy because you want a pharmacy to supply. And now your TTA, if you look here, it says written. So it's now gone into a written status. So that means that this is now ready for pharmacy to screen. If you're happy with the clinical summary, you'd press yes to clinical summary. And then enter your bleep number here. So for example, if you're carrying 337 bleep, you enter it 337 bleep, and then hit save. And it's obviously not going to save because my clinical summary is not complete. So if I do note that. So it's now moved from a draft prescription over to a written prescription. Now, if you let me just go back. Now, there are different profiles that you will see. So you'll see ready here. So that means that a discharge summary is ready and is ready for issuing by the nurse. You'll also see screened. So once a pharmacist has screened a discharge letter, then it will move into screened. Once it's ready, it means that it's been checked by pharmacy and the medications have been prepared. And issued is only issued once a nurse has actually gone through the medication with the patient and the patient's been discharged, then it'll be issued and it'll be issued to the GP practice as well. So GP will get a copy and the patient will get a copy of their discharge. Now, it's really important that we make sure that TTAs are issued, otherwise GPs won't know of their admissions in hospital, and likewise any changes to the medication or what clinical event happened to them while they were here. So it's always important that we make sure our TTAs are issued. It will only allow you to issue a discharge summary once your clinical information is complete. So it's really important that we get this prepared and correct to obviously ensure that the discharge summary isn't delayed any further. Now, usually for when you write a discharge summary, our drugs required are usually for 2 hours. So it usually takes about 2 hours for medication to be prepared, but this will depend upon obviously when the TTA is written, how busy you're in dispensary, and obviously when the medication gets screened. So we usually say an average of 2 hours, but this will depend on upon when it's actually sent to pharmacy and how busy we are down there. So for now, I'm going to put this back in discharge not complete. If you have a situation where you don't actually need any medication from pharmacy, you can select from patient's own medication. Let's say it's a short admission and you don't need pharmacists to screen it, so less than 24 hours. You may go to discharge drugs complete, yes. It's a patient's own medication, and the TTA will automatically go to ready because there's no need for a pharmacist to screen it. And this will mean that the discharge summary is ready, the clinical summary is complete, and they don't need any medicines from pharmacy, and it can therefore be issued by a nurse by bypassing pharmacy. I think that's covered everything that I can think of. There's also, just gonna have a look. There also was an interesting thing I saw on our intranet page. So if you look at the intranet page, and if you search ePro and scroll to the bottom, you'll see this general guidance documents for ePro. And if you look here, you'll see an ePro documents crib sheet. If you select it, it actually will show you a whole crib sheet on admissions, whiteboard, and discharge summaries as well. So have a look at this as well. This is a useful document that I just noticed. Jung, is there anything else you wanted me to go through? No? Can anyone hear me?
Yeah, I can hear you.
Great. Okay. I don't know where Jung's gone. Did he mention anything before he left?
No, I'm not able to see Jung, but I am having some technical issues as well. I'm able to record, but I don't know why it's getting stuck.
Okay. Well, that's just a brief run through and some directions on how to use
Thanks,
ePro. If there's anything else that you'd like us to go through, perhaps in another session, then please let us know. But I would recommend everyone look at that crib sheet. There are lots of boxes to look at, so if there is anything you're confused about or need any help with doing a discharge summary, please let your pharmacist know. Yeah, and that's it. Thank you very much.
Do you recommend we should put this presentation again for this?
I thought this presentation was cancelled, so I'm not too sure if there's enough people here. I think that's
Now we have.
okay. It's entirely up to you, Amir. It's up to you if you'd like to do another session.
Let me speak with the others.
Yeah, sure.
Whoever didn't join, so we can arrange for them as well.
Yeah, sure.
Okay.
That's fine.
Any doubts for Nav or Jung? I think in that case, thank you very much, Jung. And we have a last moment topic that has come up from Islam. Thank you very much, Islam, for joining us and presenting from Egypt.
Thank you.
So, Islam, you can start presenting your topic on DNACPR, which is quite an important topic for us.
Can you see my screen?
We can. Yeah.
Okay, so today we are going to discuss two topics, the DNACPR and the adult post-cardiac arrest care. Let's start with the first topic. What CPR stands for? CPR is cardiopulmonary resuscitation. This means when you do repeated cycles of chest compression and artificial ventilation, basically to mimic the action of the heart and the lungs. So this is usually done to a patient whose heart and lung are not working. It's a manual or mechanical effort. We're trying to mimic the action of the heart and lung to preserve the oxygen supply to the brain till ROSC is obtained, which means return of spontaneous circulation, and the heart and lung started to work again. Unfortunately, the CPR has a very low successful rate. It's less than 20% for hospitalized patient, less than 7% when administered outside the hospital, and less than 5% for elderly victims with multiple medical problems. And this can be dependent on the underlying disease, the underlying health condition of the victim, the cause of the cardiac and respiratory arrest, the time elapsed between the arrest and CPR, and the technique used by the person, if the person is well, if the team is well trained to perform CPR, and where the arrest takes place. CPR is a quite violent process. As you can imagine, you are jumping on someone's chest and doing compressions. There is a risk of injury to the internal organs of the patient. We can do fracture to the patient. We can have hypoxic brain damage after the ROSC and increased probability of physical disability. We should also think about the dignified death. If our patient, if you are going to consider CPR for someone, you are going to during the last minutes of his life, you are going to jump over his chest and doing compressions. You should think whether this patient need to do so or just let him comfortable and die peacefully. Now we go to DNACPR. DNACPR stands for do not attempt to resuscitate. Usually some patients in hospitals, we will put up DNACPR, and it's a decision made in advance, ideally, before a cash call is done. So you know which patient you are going to do to perform a CPR and which patient you are not. It's a legal requirement that the patient should be involved in the decision making and be informed about the decision made on his behalf once it is made. However, the law say that you don't need the patient consent to put a DNACPR. There is a huge misconception about that. Some people think that it's the patient decision or the family decision, which is not correct. This is a medical decision, should be done by the doctor or the medical team looking after the patient. But it's always good to have the patient and the family on agreement with the decision. And when we are talking about DNACPR, we mean CPR only, just CPR. Doesn't mean any other appropriate treatment is withheld. When to consider DNACPR, we should consider in patient with advanced stage of dying from an irreversible condition. So CPR is contraindicated in this patient. When a patient with advanced illness and deteriorating health, such as CPR will not work. When a patient whom CPR is the treatment option, but the outcome is uncertain or poor. A patient whom CPR is quite likely to restore him to a quality of life that they would value. We can also consider if a patient having an advanced directive form we can consider DNACPR if we have an advanced directive from a patient. So when the patient tell you in advance, I don't want to be resuscitated in the future if something happened, you should respect that. It's good practice to start the discussion with the patient who we are anticipating that they are at risk of dying during their hospital stay, no matter how small is the risk. So the decision to resuscitate depends on the likely clinical outcome. If the benefit would outweigh the risk, we would proceed for CPR. If this is not the case, we should think again about that. We should respect the patient's known wishes and the patient human rights according to the law, the right to life, the right to be free from degrading treatment, and we should respect all the members of the medical and nursing team, including people close to the patient. This should be solved. So to start a conversation with the patient about DNACPR, this should not be done in isolation. We should confirm the patient is understanding his medical condition, and we should assess the capacity of the patient before that. And we should start with what we are going to do for the patient. So we will tell the patient we are going to give you an active treatment. We are going to treat your, we are going, for example, to give you antibiotics for your chest infection or for your urinary tract infection. We are going to give you fluids. Then we can discuss the DNACPR. We should also respect any advanced directives. And if the patient lacks the capacity, we will seek the opinion of next of kin in the same way. It's good to have the patient and family member agreement, but again, it's not a legal requirement for the DNACPR. The Mental Capacity Act states that if a person lacks mental capacity to make particular decision, then whoever is making the decision or taking any action on that person's behalf must do this in the person's best interest. This is one of the principles of the Mental Capacity Act. A lack of capacity must have been established as a result of assessing the person's capacity in accordance with the Mental Capacity Act and its code of practice. Where a decision about treatment or resuscitation, a doctor has to act as a decision maker. The doctor has to follow any advanced care plan and should consult with all relevant people who could be interested in the specific decision, any carers, any family members, any friends, other healthcare professional, social care, and lasting power of attorney, to enable them to understand patient beliefs, wishes, views, even if the patient now lacks capacity. It's best practice to record MDT involvement in these discussions. We should record discussions in the medical notes and document on the DNACPR form as evidence of how decision is made. Now we are talking about the advanced decision to refuse treatment. That simply means that if you don't, you can now refuse a specific type of treatment in the future. For ADRT refusing CPR, it will be valid and legally binding if the person was 18 years or older with the capacity, with a full capacity at the time of the decision, It should be written, signed, witnessed, include a statement that the advanced decision is to apply even if the person's life is at risk, and the ADRT not been withdrawn previously, and the person has not, since the ADRT was initially made, appointed a lasting power of attorney. The person has not done anything clearly inconsistent with its terms, and the circumstances match those in the written and witnessed ADRT. If it doesn't meet the above criteria, it should still be taken into consideration as a part of the best interest decision. Regarding the documentation, we have a DNACPR form. You know this form. This is the photocopy of the form. This form, we have a single form which is transferable across the care, across all care settings in the hospital, hospice, home, care home, and ambulance. The original form is the patient property and follow them, but copies may be made and kept in the relevant hospital or community. Patient may be moved between care settings with valid completed forms. We should review the form, particularly if the patient is transferred to another medical responsibility. For example, even inside the hospital, if we are going to transfer the patient to the theater from one ward to another to the ITU, we should review and discuss again whether to cancel the DNACPR or just to keep it. Senior doctor should sign the DNACPR form. And in the community, it's important that the family and the informal carers are aware of a DNACPR decision. And the form needs to be kept with the patient. And the decision must be communicated to other care professionals. This is the DNACPR form. When does the family get to decide? So the family opinion should be always taken into account, but again, it's not their responsibility. It's a medical decision. They will have a legal responsibility if they have been given lasting power of attorney under the Mental Capacity Act, or acting in the patient's best interest if the patient lacks capacity to make the decision at that time. Now we are going to discuss the second topic, which is the adult post-cardiac arrest care. So we have done the CPR, and we have now ROSC, return of spontaneous circulation with palpable pulse. We are going to stabilize the patient, review him in ABCD approach, take history. We need mainly to diagnose, to know what caused the cardiac arrest. So if we have any ECG or clinical evidence of myocardial ischemia, we should perform coronary angiography first. And if we are unable to identify the causative lesion, we should do CT brain, CT pulmonary angio, and the coronary angio if the coronary angio failed. We should try to identify any respiratory or neurological cause, performing the CT brain and CT scan for the chest or abdomen, whatever the cause we are suspecting. And if there is any signs or symptoms suggestive of neurological or respiratory cause, like if the patient having a headache before the arrest, seizures, neurological deficit, shortness of breath documented or documented hypoxemic, we should perform CT brain or CT pulmonary angio. So our baseline target for all the patients is to maintain oxygen saturation between 94 and 98, to maintain urine output of 0.5 or more ml per kg or more. We should try to normalize or reduce the lactate level. We should maintain blood glucose level between 8 to 10, and plasma potassium between 4 and 4.5, and plasma magnesium and phosphate more than 1 millimole per liter. Regarding the oxygenation, Usually, we start with the maximum available FiO2, 100%, till the oxygen saturation and partial pressure are measured reliably. Then we should target saturation between 94 and 98. We should maintain PO2 of between 10 and 13 kilopascal. We should avoid hypoxemia and avoid also hyperoxemia as well. We should support the circulation. We should give fluids, vasopressors. We should first monitor the patient with arterial line. And if the patient is hemodynamically unstable, we should consider cardiac output monitoring. We should also perform early echo to trying to detect any underlying cardiac pathology and to assess the state of the myocardium. We should target mean arterial blood pressure above 65 millimeter mercury, and to maintain the urine maintain good urine output. And if we are doing targeted temperature management at 33, bradycardia is expected. We should left untreated if the patient is well used. Otherwise, we should consider increasing the target temperature, but not higher than 36. So we are maintaining the perfusion with fluids, NORAD, dobutamine, depending on the individual needs of the patient. Steroids are not given routinely. We should avoid hypokalemia to avoid any ventricular arrhythmia. We should, if our patient is having persisting cardiogenic shock, which is not responding to fluid resuscitation and inotropic support, we should consider mechanical circulatory support, such as intra-aortic balloon, left ventricular assisted device, or AV ECMO. Also, this should be considered if the patient having unstable, he is unstable and having acute coronary syndrome and recurrent ventricular tachycardia and VF. Urgent PCI should be made if we have an evidence of myocardial ischemia, for example, if we have ST elevation, or if we have elevated cardiac markers and the patient is unstable. So at that time, we should consider PCI. For the ventilation, most of the time, most of those patients will be intubated and ventilated. So we will obtain ABG, end-tidal CO2 for all these patients. We will target end-tidal CO2 between 4.5 and 6. We should monitor PeCO2 in patients treated with targeted temperature management, as hypocapnia may occur to this patient. And during the TTM and lower temperature, we should use either a temperature or non-temperature corrected approach for measuring blood gas values. And for the ventilation, we should use the lung protective strategies, giving tidal volume between 6 and 8 mils per kg of the ideal body weight. So for the D, disability and neurological point of view, we should control seizures. If we have seizures, we should perform EEG to diagnose it and to monitor treatment effect. And we should use the levetiracetam as and in addition to, hello?
Islam, I think you're getting disrupted frequently. Can you hear us?
I'm hearing you now.
Better.
Okay, can you hear me now?
Yeah, it is better now.
Hello? Yeah, okay. So for the seizure control, DNACPR and the sodium to the sedative drugs, but routine seizure prophylaxis is not recommended for all post-cardiac arrest patients. The targeted temperature management, we are aiming temperature between 32 to 36 for at least the first 24 hours. We should avoid fever. Temperature shouldn't be above 37.7 for at least 72 hours after ROSC. And if the cardiac arrest occurred outside the hospital and we are transferring the patient to the hospital, we shouldn't use cold fluids to initiate hypothermia at this setting. In the intensive care, we should use short-acting sedation and opioids. We should avoid neuromuscular blocking if possible, but it should be considered if the patient is having severe shivering during the TTM. DVT prophylaxis and stress ulcer prophylaxis should be routinely provided. The blood glucose should be maintained between 7.8 and 10. We should use insulin infusion if required. We should avoid hypoglycemia because it can damage the brain. We should start enteral feeding at lower rates during the TTM, and we can increase after rewarming if indicated. If we are targeting a temperature of 36, then gastric feeding rate may be increased early during the TTM. Routine prophylactic antibiotics are not recommended for these patients. Regarding the long-term outcome after cardiac arrest, the functional assessment of physical and non-physical impairment before discharge from the hospital to identify early rehabilitation needs and refer to rehabilitation if necessary. And we should, for all survivors, we should follow up within 3 months after hospital discharge. This should include screening for cognitive problems, screening for emotional problems and fatigue, and providing information and support for survivors and family members. Last thing we are going to talk about is the organ donation. So organ donation should be considered in those who have achieved ROSC and who fulfill neurological criteria for death. In comatose ventilated patients who don't fulfill neurological criteria for death, if a decision to start end-of-life care and withdrawal of life support is made, organ donation should be considered for when circulatory arrest occurs. Thank you.
Thank you very much, Islam. Anybody has any questions? So I guess Islam will stop your presentation now. Thanks a lot. And we'll see